symposium, which is related to discuss advances in functional gastrointestinal disorders. We've got 3 talks talking about non-pharmacological, then pharmacological treatment of functional abdominal pain, and then the role of the pediatric surgeon in functional constipation. We'll hold the 3 talks and then have a
I can't hear you anymore.
He's muted.
Can I start by introducing Professor Mark Benninga, who is the Professor of Pediatrics in the University of Amsterdam, who's going to talk to us on the non-pharmacological treatment of functional abdominal pain. Mark, thank you.
Thanks, Mark. Thanks for the invitation to speak today. And I'm happy to talk about non-pharmacological treatments in functional abdominal pain. I will review the current non-pharmacological treatments. I will present evidence data on foods in children with functional abdominal pain. I present, of course, evidence on behavioral therapies like cognitive behavioral therapy and hypnotherapy. And I also shortly will discuss future treatments. So as you all know, we nowadays use the Rome 4 criteria to diagnose different clinical entities with respect to nausea, abdominal pain, and defecation. And this presentation will deal with the functional abdominal pain disorders. As you know, functional dyspepsia, irritable bowel syndrome, abdominal migraine, and functional abdominal pain. And today I will only discuss the treatments for irritable bowel syndrome and functional abdominal pain, not otherwise specified. And as you all know, it's very difficult in children with abdominal pain, if it's in the head, or is there something wrong with other organs? And this is also always a very big discussion with patients and with parents. And these are really nice new data from Boston, where they looked at the perceptions of pain treatment in pediatric patients with functional gastrointestinal disorders. And as you can see, people knew were aware of the different strategies we use for we could use for abdominal pain, like exercise, medication, behavior therapy, acupuncture, biofeedback, and most of the parents are aware of the different treatment options. Also, the perception about pain was nicely reported by the Boston group. The parent and the child attributions to the biological causes, like sensitive stomach, the role of foods, the role of infection, eating too fast or too much, but they also thought about the attribution of psychological causes, like being nervous or stress in general, stress from teacher or stress from internet, and etc. And as you can see from both graphs, many people are aware of the causes of the different abdominal pain, but they are always uncertain if it's really related to the complaints. And the expectations of the treatment helps. And this is a table in which is shown where the parents and the children were happy or not happy with the treatment and what they suggested would be helpful for them. And as you can see, if the doctor gives a definite diagnosis of a functional gastrointestinal disorder, they were relieved and were happy with a final diagnosis. Medical testing, they were not sure it would really help them. And the same was true for surgery. They fully believed that this would not be helpful for their child, their child's treatment of abdominal pain. Surprisingly, hypnosis, acupuncture, massage, or psychotherapy, where in the majority of parents were in favor of these treatments, whereas the children were not sure it would help diminishing their and improving their abdominal pain. So they concluded, the conclusions from this very nice paper was there is a desire from both the parents and the children to have a clear explanation for their functional gastrointestinal disorder. And many patients and their parents did not perceive that they had received a diagnosis before multidisciplinary evaluation despite numerous provider contexts, and this may reflect provider uncertainty, patient-provider communication failure, or both. So indeed, we need to be clear that we are sure that it's a functional gastrointestinal disorder. So what is the evidence we currently have regarding the treatment of non-pharmacological treatment for these children? Well, there's hardly anything. This was a systematic review from 2015, and there will be more children included in studies, but if there are now 2,000 children aged 3 to 18 years, then I think it's a lot. And in these trials, they evaluated fibers, lactose-free diet, probiotics, hypnotherapy, cognitive behavior therapy, yoga, and written self-disclosure. There were no studies until now evaluating the effect of lifestyle, prebiotics, acupuncture, massage, etc. The first line treatment is, of course, that we have to encourage a positive attitude, but give the parents and the patient realistic expectations. So we should discuss and reassure. We should discuss the prevalence of FGID. Most of the time, it's a benign clinical course, but of course, there can be relapse of symptoms. And we have to acknowledge that, that there's often a significant impact on quality of life. And also, I always will discuss this study before I start treatment of these children. And this is a very nice paper, already 15 years old, by Lynn Walker and her group, and she used a water load drink test. So patients had to drink a cup of water filled with 100 cc, and after every minute they had to drink another cup with water. Parents were divided in 3 groups. One parent group had to give attention, so they have to say after every sip of water, are you okay? Do you feel nauseated? Do you have pain? They should, 1/3 of the parents were instructed to give no instruction, to say nothing, and 1/3 of the parents was instructed to distract their child. And as you can, and as it is not a surprise, those children who received attention from the parents, both the pain children and the healthy children, had a significant more pain than those who received no instruction or distraction. But the most important conclusion of the paper was, at the end of the study, that all mothers felt that distraction was inappropriate response to pain. So I always tell these parents not to discuss pain, and then discussing this paper and how it influenced the behavior of the child. So what about food? I just show you this slide to show you that in Gut 2015, there's a paper on the different compounds of food, like carbohydrates, lipids, proteins, and food chemicals, and how they can result in irritable bowel syndrome symptoms. I don't go into detail in the different substances of the food. So what about fibers? Well, this was tested this was reported in this systematic review. And as you can see from the slide, in the studies which were performed, the randomized controlled trials, there was no benefit of adding fibers to a diet of abdominal pain-related functional gastrointestinal disorders. This is gaining much more popularity right now, the FODMAP diet, the fermentable oligosaccharides, disaccharides, monosaccharides, and polyols. How does it work? You ingest those carbohydrates, it accelerates transit by the acids, and there's a production of gas, which gives rise to abdominal pain, flatulence, and a distended abdomen. So lowering the diet in FODMAPs would improve the abdominal pain symptoms. This was the key paper, which was published in Gastroenterology, which compared a typical Australian food with a low FODMAP diet, and as suggested, there is less gas production by using the breath hydrogen test in those patients, in those people who used a low FODMAP diet. And this was also true In adults with irritable bowel syndrome, they had less complaints of abdominal pain, and there was less bloating and less passage of wind. Is there any evidence in children? Well, this was the first paper published in 2015 by a group in the United States. However, this was a very small group of children, and there was only the low FODMAP diet was only used for a period of 1 week. And in this particular paper, there seems any benefit, some benefit of this diet in those children with abdominal pain. But again, the group was very small, and the duration of the FODMAP diet was very small. And we do know that it's very difficult, both for adults, but especially for children, to keep the diet for at least 6 weeks. Then only recently, this paper came out from a Polish group where they compared in 30 children in a randomized controlled trial, and they compared the low FODMAP diet and a diet based on the NICE guidelines. There's too short time to go into detail into the different diets. But what was spectacular, that the low FODMAP diet was less helpful compared to the NICE group diet with respect to abdominal pain intensity and abdominal pain frequency. So looking at the data of this trial, this also small trial, the low FODMAP diet was not as good as the diet as proposed by the NICE group. What about probiotics? Again, there are many strains available, but if we look at the effect of the different strains like the Lactobacillus gigi, this is an older paper from 2011 showing that only in those children with irritable bowel syndrome, this particular strain, Lactobacillus gigi, might be effective compared to placebo. In functional dyspepsia or in functional abdominal pain syndrome not otherwise specified, it seems not to be beneficial to use this particular strain. However, a larger recent double-blind randomized study using the Lactobacillus reuteri indeed showed that there was a difference in pain intensity between those children receiving the Lactobacillus reuteri and placebo. Again, small studies, so it's too early to draw firm conclusions. So what about cognitive behavior therapy? More literature is on this specific therapy in children with abdominal pain. This is a study by Rona Levy from the United States, including 200 children, and she used a 3-session intervention of cognitive behavioral treatment, especially targeting parents' responses to their children's pain. By relaxation training, working with parent and child to modified family responsive and cognitive restructuring. And she was able to show a significant difference between those children who received this specific program compared to these parents who did receive the standard therapy by the psychologist. So this study clearly shows that cognitive behavior therapy is helpful in children with abdominal pain. The people from Sweden used the internet and also showed a beneficial effect in adolescents with irritable bowel syndrome when using an internet-delivered cognitive behavior therapy program compared to a waiting list. And also it improved quality of life in these children, and compared with the usual treatment was more cost effective. More importantly, after having this specific internet training, the treatment success sustained 6 months after treatment. So these studies clearly show that cognitive behavioral therapy have a place in the treatment of functional abdominal pain disorders. What about the use of complementary medicine in these patients? We and others showed that many people coming to our outpatient clinic use at least one complementary medicine modality. Some of them use dietary changes, multivitamins and probiotics, and a small portion also go to a psychologist. I hope you can read it, but some also do stress management. They pray, they use music as therapy, aromatherapy, well, all kinds of different complementary medicines. Children with self-reported severe disease more likely to use exercise, whereas those with active symptoms or in high income group persons more likely to use dietary changes. Those without private insurance or who felt poorly informed regarding complementary medicine more likely used vitamins and supplements. So the next topic is hypnotherapy. And in the last 15 years, we worked very hard to introduce this kind of therapy in children with functional abdominal pain disorders. As you all know, this is not hypnotherapy. It's based on a standardized protocol made by the group of Peter Warwell, a gastroenterologist working in Manchester. Hypnotherapy consists of 6 sessions, including general relaxations with breathing exercises, control of abdominal pain and gut functioning, and also included ego strengthening suggestions. Keep in mind that the child is always in control. So now more than 10 years ago, we showed in a group of 60 children that hypnotherapy was significantly better in improving abdominal pain compared to the standard medical therapy, including painkillers and acid blockers, diets, and laxatives. And this was not only seen after 3 months of therapy, but the improvement even increased after 1 year, showing an effect of 80% in the group children who received hypnotherapy compared to those who received standard medical care. And even after 5 years follow-up, there was a significant difference between those children who received hypnotherapy compared to those children who received the standard medical care. During those years, Miranda van Tilburg, a psychologist working in the United States, used CDs to give the hypnotherapy sessions. And she was also very successful compared to the standard medical care in improving abdominal pain. And after switching to hypnotherapy, there was a success rate of almost 60% in those children who failed therapy after having the standard medical care. And this was the reason that we set up a large randomized controlled trial, including more than 250 children, comparing hypnotherapy given by a therapist compared to a CD group on which the different sessions of the hypnotherapy was listed. And as you can appreciate from this slide, there were the different IBS subgroups, and the duration of symptoms in this patient group was almost 2 years. School absenteeism was high, with 86% of the children having school absenteeism. And we were surprised that using after statistical analysis that after 3, 6, and 12 months, there was no significant difference in frequency and pain intensity score between those children who received hypnotherapy by a therapist and the exercises which were listed on a CD, which clearly means that the CD, which is much cheaper than the individual hypnotherapy, is a helpful alternative to give hypnotherapy in this group of children. Also, very importantly, if you ask patients and parents about adequate relief, then compared to the strict criteria we use as doctors, the majority of parents and patients is very happy with the treatment either by CD or the individual hypnotherapy. It also improved anxiety, depression, quality of life, and pain relief, but did not have any effect on the type of IBS or functional abdominal pain disorder, and more importantly, it was not dependent on the therapist. These data are not published yet, but we indeed again showed that there is a long-term success after having therapy either by the CD or the individualized hypnotherapy by a therapist. So in summary, hypnotherapy next to cognitive behavioral therapy is a very successful treatment for children with abdominal pain. We don't know exactly how it works. However, functional MRI has shown that the pain centers involved in adults with irritable bowel syndrome are differently activated compared to control and healthy persons, as you can see clearly on this picture. And hypnotherapy during hypnotic suggestion reduces suffering from abdominal pain. Yoga therapy is also asked if this is helpful for children with abdominal pain. It increases physical flexibility, coordination, and strength. It also uses breathing practices and mediation of calm and focus the mind to develop greater awareness and improve cardiorespiratory parameters. And of course, there's a reduction of chronic pain, reduce symptoms of anxiety and depression. And this study performed in the Netherlands shows that yoga indeed is effective compared to controls, although the pain intensity and the frequency scores are similar in the first 6 months after treatment, but we do see a significant difference of yoga compared to controls after 12 months. More importantly, that in both groups, attention given by the doctors using the standard medical care and using yoga resulted in a decrease in school absence. So yoga might also be an alternative treatment for children with abdominal pain. The osteopath, always a difficult topic. I never send patients to the osteopath. There are some data, but the data are small and there's a limited number of studies and the sample sizes are very small. So it's again, it's too early to draw firm conclusions about the effectiveness of osteopathic manipulative therapy for abdominal pain. This study is very promising. It was introduced by Katja Kovacic from the United States, and she used percutaneous electrical nerve field stimulation to modulate central pain pathway. The effects were already shown in an animal model, showing that that the hypersensitivity could be reduced using this nerve field stimulation. She was able to include 115 adolescents and compared the nerve field stimulation with an active device or a sham device. It's important to look at the data of this study because 7 patients out of the 50 patients who were assigned to the treatment discontinued because of needle phobia, aesthetic reasons. One experienced the device as uncomfortable and one had an adhesive allergy. So we have to keep in mind that these might be the reasons to not use these kind of devices. The results are striking because there was a significant difference between those children who used the actual device compared to the sham device with respect to pain, symptomatology, and functional disability. So again, this is a new device. I'm not aware that this is already available in Europe, but I know that this is more frequently used in the United States for these kind of patients. So finally, what's about the microbiome? Well, studies have shown that there is a difference in the makeup of the microbiome if you compare children and adolescents and adults with irritable bowel syndrome compared to healthy children. And based on these studies, people started to use fecal transplants to treat adults with irritable bowel syndrome. In the Netherlands, we are experienced in using fecal transplants for different reasons, for type 1 diabetes, for inflammatory bowel disease, and so also for people with irritable bowel syndrome. A meta-analysis published in 2019 showed, evaluating 4 studies, 4 different studies, that there might be not a huge effect of fecal transplants in adults with irritable bowel syndrome. But there was a discrepancy because of the differences in the route of administration, the placebo treatment, and the fecal transplant frequency. It might be the case that a new study which was published only a few weeks ago, that a super donor is necessary to be successful in adults with irritable bowel syndrome. They were able to include a large proportion of patients with IBS, diarrhea, constipation, and a mixed form of IBS, and when they analyzed the microbiome, 64% of the patients had dysbiosis, and they used a particular dysbiosis scale. And if we look at the super donor, which is in the middle of this plot, then this super donor was recognized having no dysbiosis at all. And this male, a 36-year athlete with a very healthy diet, was used for the transplantation of all these patients. And there was a significant difference between those adults who received placebo and the amount of feces given, so 30 grams or 60 grams. And as you can appreciate, there was a significant difference between those people who received either 30 or 60 grams with the placebo. So it seems that this super donor might be the clue in successfully treat these patients with abdominal pain. Of course, there are adverse effects of fecal transplantation, like nausea, diarrhea, constipation, but there were no reports about taste or smell. So this last study published in Gut shows that fecal transplant improves abdominal symptoms, fatigue, and quality of life, but it might be the case that the use of a super donor with normal dysbiosis might be the clue in the success of fecal transplants. Finally, there is of course a role of placebo, and we were very much surprised that 41% of patients who receive a placebo, of pediatric patients receiving a placebo, was successfully treated for abdominal pain. So indeed, there is a role for a placebo, but I don't know how it is in the rest of the world. In the Netherlands, we are not able to give a placebo to our patients. And what happens if you do nothing? You're only very nice and kind to your patients. This was a study from Italy. And as you can see, even if you don't do anything but be kind to your patient, then there's a spontaneous resolution of symptoms over a 2-year period of follow-up. So in conclusion, successful management of patients with functional pain disorders are helped by with a trusting, positive, and patient-physician relationships. Fibers and probiotics I've shown you have only play a minor role in the treatment of these children. The role of FODMAP is uncertain, but the study from Poland has doubts about the role of FODMAP, and we have to keep in mind that it's very difficult for both parents, but also especially for the children, to keep the diet for a longer period. The randomized controlled trials clearly show that cognitive behavior therapy and hypnotherapy are very effective treatment for these children. There's a role, of course, for placebo, for neurostimulation, not for osteopathy, and function. And the role of fecal transplants has to be proven in children in future studies. I thank you very much for your attention.
Thank you very much, Mark. Great talk, and it's always an absolute pleasure to listen to you, your great expertise and innovative thinking about how to manage this difficult group of patients.
Thanks.
I'm going to now share my screen, and start my talk. So I'm going to talk on the pharmacological treatment of functional abdominal pain. It's quite a tough one because I very much like Mark Benninger has tried to focus my attentions as a practicing clinician on using non-pharmacological treatments where possible, which are by and large better evidence-based and more effective. So I'm going to reflect a little bit on the diverse presentations of functional abdominal pain and their relevance to specific treatment, talk about the evidence base, and finish with a brief discussion of practical management. So the most important thing is that abdominal pain is so common, it's unusual for a child to go through school years without experiencing it at some stage. And it's poorly understood, with many, many different factors causing it, and symptomatology which can be quite vague, a low yield of organic diagnosis, and many, many, many different subjectively based treatment strategies. One of the most important thing is, and it's important to remember when we see a child with recurrent abdominal pain, is that for every child that attends your clinic with pain, there's another child who doesn't get to the clinic. And therefore it's not the pain itself, but it's the impact of the pain that gets the child to visit the doctor. We see recurrent abdominal pain all over the world in any setting that it's being studied. And in any setting it's being studied, there's an association with anxiety, depressive disorders, stress, and traumatic life events. And that reflects the diversity of the condition. So the Rome criteria, and I'll just say the Rome criteria has been redone in 97, 99, 2006, and 2016. And it's meant there's been changes and modification and refinement of definition. But the intention really is to attempt, and it's not always possible, to split the patients into subgroups, and these are them. And so they're functional abdominal pain, cause not specified, abdominal pain with symptoms of dyspepsia or non-ulcer dyspepsia, irritable bowel syndrome, and abdominal migraine. And just to remind ourselves about those subgroups, because they're very relevant to how you might or might not think to treat. So functional dyspepsia must be there for at least 2 months before the diagnosis can be made, at least 4 times a month, and has no underlying organic cause after appropriate evaluation, and a wide differential diagnosis. And 2 subgroups which people recognize in both pediatrics and adults, which are postprandial distress and epigastric pain. So they have a difference in how they present and perhaps a difference in how they should be dealt with. Irritable bowel syndrome, which is very, very common in children, and it's on a spectrum with functional abdominal pain. So it's difficult to totally separate these off, but it's common. It can be constipation predominant or diarrhea dependent or a mixture of both. But it does have some treatments that can be used, which are helpful if that specific phenotype is isolated. And I think a very underdiagnosed condition is abdominal migraine, and that's where the pain is episodic with completely symptom-free periods in between, and with somatic symptoms associated with it, such as anorexia, nausea, vomiting, headache, photophobia, and pallor. And then there's the group which is the bigger group, the more difficult group, and the challenging group are actually the one that we're mostly trying to focus on this afternoon, and that's functional abdominal pain, otherwise cause not specified, when other functional pathologies have been eliminated and serious underlying organic disorders have been eliminated. But in a way, that's where we sometimes get into problems, because an important feature of any functional condition is that it can occur in conjunction with an organic condition. And certainly some children with serious underlying organic disease like cystic fibrosis and inflammatory bowel disease can suffer from very severe functional abdominal pain in addition. And therefore the recognition, separation, combined management of the two is challenging but important and has real relevance to how you manage a child with a serious disease. So visceral hypersensitivity, Mark's talked about some of these issues, but visceral hypersensitivity helps me think about how to best deal with a patient with functional pain. And that's really that our pain thresholds vary. They vary because of other things around us. They vary because of the environment we're in, and they vary because of the stress responses that occur when we suffer from them. And you can well see that a child can have its perception threshold shifted by straightforward interventions, recognition of the condition, and a very open and considered discussion with the clinician, and that can impact significantly on outcome. And that's where you have to consider stress. Physical stress, psychological stress, or a combination of the two. It's important to all of this, and it's particularly important when you're starting to think about giving drug therapy, and particularly important when you start to think about giving investigations, because if you don't get the family on board with the functional concept, you're unlikely to help impact long-term on the child's symptoms. And this is just a very small study, and all the studies in functional pain are small, but this is 28 children, 20 had pain for more than 6 months, 50 with associated anxiety and depression. At follow-up 6 months later, 50% continued to complain of pain. So only 1 of the 14 parents of children with ongoing pain felt there was a potential psychological cause, whereas 11 of the 14 parents of the children who had recovered believed that the cause was attributable potentially to psychological factors. There's an amazing odds ratio there of 50 or so to 1 with a wide confidence range. But it does show the acceptance of this biopsychosocial model, and therefore the potential to impact on the patient's symptoms is crucial. So what about the assessment? Because I now have got to get to thinking about the drugs, and that's what we'll move on to. So good history, good examination, basic tests, positive confident diagnosis, and a positive and rehabilitative management strategy, as Mark has said. And of course, we're not going to miss alarm symptoms, and we're not going to miss rare diseases. But do remember that you can have functional symptoms and an organic disorder at the same time. And we've got to think about how pain is dealt with, because we can't impact pain unless we find out how that pain is dealt with within a family setting, and in particular, how it's dealt with in the family overall environment. And that's where people should think about a family illness history. So if there's multiple illnesses in this family, how are those illnesses dealt with? And of course, we limit investigations. And we do that because without specific pointers, the diagnostic yield is low. But we also should do it because it's very easy for clinicians to do tests and much harder for them not to. But actually, you gain a therapeutic partnership with the family by being open and honest and not resorting to too many CT scans, MRIs, and endoscopies. And you have a rehabilitative biopsychosocial approach to management, including interventions like psychology, like hypnotherapy, like dietary changes wherever possible. And this is the key sentence: you avoid excessive medications. In my practice, I try very hard to avoid excessive medications. And so in every review of recurrent abdominal pain, there'll always be a slide like this. And it's a slide which sort of tells everyone, well, I'm just not happy with the evidence base. There isn't very much evidence for any of the interventions, and where do we go from there? And this always presents us with some difficulties. So we know, Mark has said, that psychological therapies are helpful. We know that hypnotherapy is helpful. The most recent paper in Frontline Gastroenterology from the Manchester group, fabulous outcomes of hypnotherapy in adolescents with irritable bowel syndrome. So we know they work. And we know there's some data that probiotics work, but it's fairly variable, it's fairly inconsistent. But what about the drugs? Well, this is a great Cochrane review. It's a Cochrane review from 2017. I mean, it's great because actually what it really says is drugs don't generally work, but this is the main result. 16 studies, 1,000 participants, looked at tricyclics, antibiotics, 5-HT antagonists, antispasmodics, antihistamines, H2 receptor antagonists, serotonin antagonists, etc. And found that really, with the exception of small single studies, there was very little evidence for efficacy, and none really had results that were sufficiently robust to recommend for treatment. I think a lot of that relates to going right back to the beginning of the talk that I'm giving now, is you've got to categorize the patients first. You've got to think about other factors that might be relevant to their symptoms, and therefore in selected groups of patients with functional abdominal pain, it may be quite appropriate, quite sensible, quite helpful to give specific medications, and that they might be very helpful. So back to abdominal migraine. So remember, abdominal migraine, specific phenotype, pain with symptom-free periods and somatic symptoms associated with it, often a history of headache, often a family history. And in that group of patients, we know that dietary intervention is helpful, but we know also that there's a medication called pizotafin, which works. So pizotafin working in migraine has been well established in clinical practice, certainly in the UK, throughout my whole pediatric career. And I still regularly see patients with this phenotype who go on to pizotafin and who find it effective, and it virtually, not completely, but virtually remits their pain. It's just interesting to look at the data. This was quite a small study. It was a crossover study of 14 children. And it did show very convincingly that there was a reduction in days of pain, severity, and misery. And it was very widely publicized at the time. I do remember, because it's 1995 when it was published, when when I first was appointed as a consultant, and I remember the paper coming out and its impact. But it's interesting that that's not much data for a drug that does work. And it always makes you wonder as to how you interpret the literature out there and how you add the literature out there to people's clinical experience. Functional dyspepsia, I think this is quite a hard condition to diagnose, because you worry when you're seeing a child with dyspeptic symptoms as to whether you're missing an ulcer. And it used to be said that if you had epigastric discomfort that woke you at night, then that meant you should have an endoscopy. And I don't think people think that now. But, you know, this group of patients are quite complicated, and there's all sorts of treatment. And in an amazing review recently published in Nature Reviews, there was a sort of summary of how you might approach the treatment of functional dyspepsia. And I'll just pause so that we can look through it for a minute or two together, but it includes lots of drugs that can potentially be used, some of which have got a good evidence base and some of which haven't. And it is interesting then that you can think, well, it would be very easy if you've got functional dyspepsia to end up on first to start off perhaps with some H2 blockers, then some PPIs, then lactobacillus to return your bacterial flora to normal, and perhaps some antibiotics, and perhaps some buscopan or some beverine. And then some antiemetics. And I think this is quite a tough one, functional dyspepsia, because often these patients, none of these medications respond, and that would be supported by the evidence. And actually sometimes adding the medications together make the situation significantly worse. So I think we've got to be careful that when we're thinking about drugs in this group, that we firstly use them as a trial and stop them if they don't work, but also in recognizing that if they don't work, not necessarily switch straight away to another medication. So this is an interesting group of patients, very common in a pediatric clinic, very common in a pediatric gastroenterology clinic, and very important not to over-investigate. So what can we learn from the adults? And I think what I've learned working in a hospital that looks after children and adults together is that many of the symptoms and signs that we see in pediatrics are similar to the symptoms and signs that the teams see in adults. And this is a systematic review recently published in Alimentary Pharmacology and Therapeutics, which just looked at the efficacy of drugs for functional dyspepsia. And just remember, functional dyspepsia is making the assumption you haven't got a ulcer or esophagitis or an eosinophilic esophagitis or any other serious organic pathology. So it's quite a complicated paper, but if you look at the various drugs used, then firstly you can rank them. So the commonest used drugs actually are things like antipsychotics, and that's amitriptyline, H2 receptor antagonists, PPIs, but actually their efficacy is not fantastic when compared with placebo, and that their efficacy for resolution of symptoms is even less good. So you're talking about only very marginal gains. So it's quite an interesting study, and it's quite interesting to look at this from an adult gastroenterology perspective, where they are, like us, receptive to trials of medication, but actually like us a little bit anxious that many of the medications that you use don't work. And actually, although I'm not there to focus on non-pharmacological treatments, you might just assume that in a very significant group of patients with functional dyspepsia, dietary intervention and exercise and other lifestyle factors may well be more important, with then a better ability to select out the small group who need investigation. So irritable bowel syndrome, I think one of the things about functional abdominal pain is quite a number of the kids have incomplete rectal evacuation, and they respond well to trials of laxatives. And if you're going to then think about a child with functional abdominal pain, it's quite important to work out, have they got irritable bowel syndrome as well, or have they got constipation dependent irritable bowel syndrome as well, because that would just make you think about where you might or might not go with medication. And just to summarize some of the evidence from another paper by the same group, which is Alex Ford's group from Liverpool, that if you look at all the different treatments you can potentially use for irritable bowel syndrome, and hey, this is a very long paper, and rank them in terms of efficacy. So this is ranking them so that the number one is the one that works best. Then you see here peppermintol straight away. So 6 randomized controlled trials in adults, 342 patients with good efficacy in terms of improvement in global symptoms and reasonable efficacy in terms of improvement in abdominal pain. Interestingly, although the trials are generally smaller, there's a fair amount of data on tricyclics in adults, and there's data that suggests that although antispasmodics are used, they're not terribly effective. But I mean, it's just interesting to look and see what the adult data shows. So going back to the Nature Reviews paper, there is an algorithm of how you might consider a child when they have functional abdominal pain with an irritable bowel syndrome phenotype. And based on reasonable evidence, some of which I've summarized, you might try laxatives, probiotics, cognitive behavioral therapy, and pharmacotherapy for constipation predominant, and you may try these other strategies for diarrhea predominant. But mostly, you have to be very careful that you don't overtreat with multiple therapies that are not effective. So if we go back to functional abdominal pain not otherwise specified, I always get to this point of a talk and think to myself, well, do I really believe that's a definite, separate, defined group? And I think these different categorizations do certainly may emerge. But within that group, there's a very difficult patient grouping, which are the ones who've got additional somatic symptoms, and they're quite challenging to treat. And they're the ones that, in my personal experience, I would say benefit the most from non-pharmacological interventions. But looking at this, there's some evidence for probiotics. MARC has already talked about that, and that's because probiotics are somewhere between a pharmacological and a non-pharmacological treatment, but there's some evidence for probiotics. And there's some good evidence for peppermint oil. And this is a study from the Iranian Medical Crescent Journal from 2015, but you know, it's a lot of patients, and the efficacy is reported as being very good. And there are plenty of other studies in adults on peppermint oil. So peppermint oil, either capsules or liquid, is certainly a benefit. But these are interesting. So you hit something like Buscopan, so very, very, very widely prescribed in the UK. And there's very minimal data. And so this is 236 children reported who were randomized to have Buscopan or placebo. I think this is just an abstract because I couldn't find the full paper, but actually no difference between buscopan and paracetamol, looking at a visual analog scale. And so that's quite important that we think about medication like buscopan. Well, does it really work? Similarly, mebeverine, a single placebo-controlled RCT, showed a statistically non-significant decrease in pain. So if you're thinking about evidence, statistically non-significant means it's not significant, so it's just by chance. And this is this study which was reported in Biomedical Research International. It is a good, well put together study with 115 patients randomized, but it doesn't show significant efficacy. So, you know, these are drugs without very much of an evidence base, but we could say that many of the other things we do in medicine haven't, but it does mean you've got to be very cautious about their use. Tricyclics are widely used in adults. I've shown you data for that already, and they're widely used in North America by pediatric gastroenterologists, but the data on that is pretty sparse. And this is a multi-center randomized placebo-controlled trial of amitriptyline in children with functional gastrointestinal disorders. It's a horrendous slide, this, and I couldn't get it to look any better. But if you just look at the p-values, so the p-values for overall improvement and improvement in pain are non-significant. So this is a large trial of amitriptyline in children with functional gastrointestinal disorders, which didn't show primary efficacy. And this is quite interesting. So what it showed was that both groups improved. So Mark alluded to this at the end of his talk. That's the placebo group and the amitriptyline group both got better. What about HT2 blockers, PPIs and laxatives? Certainly in my part of the world, I see a lot of these children that have already been put on omeprazole, and sometimes stopping the omeprazole makes things better. But there is a small RCT of famotidine, which is an H2 blocker, which shows reasonable efficacy, or at least subjective clinical improvement, but not necessarily reduction in pain scores. And there are no good trials of PPIs or laxatives in functional abdominal pain. So this is this study, and it's in digestive diseases from 2001. So you go back to the Cochrane review, and that's why I say it's really good Cochrane review, because it says there isn't much evidence for using pharmacological therapies in recurrent abdominal pain of childhood, and therefore, you know, be jolly cautious about using drugs. I think the rider to that is that there may be specific phenotypes within the categorization which do benefit, and we should at least be open to that. So back to the slide of evidence base is limited. So if we try to pull this talk and the previous talk together, you say, well, if you've got an 11-year-old boy with a 3-month history of abdominal pain and fatigue, and school attendance is less than 50%, well, what do? Well, you try and deal with the problem that the patient wants dealt with and the family do by a really good history and examination, and considering all the factors, including how the pain is dealt with, and in particular, whether there is anxiety and stress and whether they need to be dealt with by psychological intervention. And you remember that just because you've got an organic disease, it doesn't mean you can't have functional pathology. I find it useful to think about the functional dyspepsia, abdominal migraine, IBS phenotypes, but also then to remember that they all have significant crossover. Don't do too many tests and don't give too much treatment. But the treatments you can give are a confident, clear diagnosis with appropriate multidisciplinary input as available, insisting on the inseparability of physical and psychological problems, and using medication sparingly and only if indicated. So functional abdominal pain, it's common, multifactorial, diverse in its presentations. We don't want to do too many tests. And actually what Mark and I hope I are trying to show you is reflect on the evidence available. And actually the evidence base for non-pharmacological therapies is probably better than the evidence base for pharmacological therapies. Remember, they don't always do well. And I'm just going to finish with this. And this is why it's important to have these talks and to have consideration of this condition, is that we know that there are many determinants in childhood of adult disease. And one of them is functionality. And so this is a study published in Pediatrics back in 2013, where there was a comparison between children with functional pain in childhood with controls and how they were as adults. And what that showed is that if you have functional symptoms as a child, you've got a 40% incidence of functional symptoms as an adult, compared with controls at 7.5%. But also, and perhaps almost more importantly, that those functional symptoms you might suffer from as an adult include an increased incidence of depressive disorders and anxiety disorders, and that's statistically significant in whatever age is considered. So it's just really a thought to leave you with, but it's a thought about how we must do better for this patient group. Thank you. So we're going to move now on to the third talk, and I would now like to welcome Dr. Justin de Jong, who's a pediatric surgeon from Amsterdam, to talk us through the role of the pediatric surgeon in functional constipation. And I'm very much looking forward to hearing the talk, and then we'll have some questions after that. Justin, I think you're on mute.
Good afternoon, everybody. This is Justin de Jong speaking from home to the audience. I'm one of the pediatric surgeons of the Amsterdam University Medical Center. And next. Okay. It's impossible to go to. I show first, before we go on, it's later in the afternoon, and we have had some serious talks. I show you some pictures of our recently renewed hospital, this beautiful hospital. And normally, if there was no corona, you would be in the beautiful city of Amsterdam. And Amsterdam, this is a view from above, from the plane. You see the beautiful city center, and the head of the hospital decided to start when there was a fusion between two of the university hospitals in Amsterdam. They wanted to start with a new logo, and decided to go on with the logo you see on the right side. And in first instance, when I saw the logo for the first time, I thought it was wrong and that it came from the head of the Department of Gynecology. Maybe you have the same thoughts about it, but it wasn't. It was wrong. But when you compare this configuration with the view from Amsterdam, you see it is a form like a tulip, and this. Why a tulip? Now, there's not only the formation of the city center, but it's also the history. We had in the past Nicholas Tulp. He was a famous major of Amsterdam, and he became very famous because of he was painted by Rembrandt van Rijn in The Anatomist. Is the painting you see on the right side. And 12 years ago, I came from another university hospital, and I entered the University Center of Amsterdam, and then I entered a new world, and a world I didn't know that it exists before. It was the world in which I met my good friend and colleague Mark BENNINGA, and he's a very special, enthusiastic, empathic doctor, and he has a very special room in the hospital, you see on the right side, and he had a very special hours every week, and this, in normal English you call it the outpatient clinic for defecation disorders, but in the Netherlands we call it the poop poly. And when I started there 13 years ago, I heard Amsterdam was a very special hospital because Mark was working there, and for we saw every year 250 to 300 new patients a year, and with functional constipation problems, and also 100 to 150 second opinions a year. Now, the background for functional constipation, most of you are pediatricians, know that it's a common disease. It represents 3% of the visits to pediatricians and even 25% of the visits to the gastroenterologist. And that after 10 years of intensive therapy, 20% have persistent functional constipation or intractable constipation. Now, the symptoms you all know, patients with everyday pain, school absenteeism, and reduced quality of life. The gastroenterologist and pediatricians are using this algorithm to treat functional constipation, and you see on the bottom there's a small area for surgery. It is in Amsterdam, Mark modified the algorithm to the so-called treatment pyramid for functional constipation in children, in which he treats the children from the back, climbing up the hill, and there in the top, yeah, there's the surgery in there. It's me. And despite all efforts, you know that there are a lot of patients who are not doing well, and after extensive therapy, some for maybe many years, they finally end and were sent to Amsterdam, and the parents were very upset, and they say, we have been treated for many years, and now you tried everything, something has to happen now. Now then what you are doing then is called a surgeon. And now in the case for surgeon, it's failed conservative therapy, and all organic causes should be ruled out. Now, we as surgeons have a lot of things we can do, right? The so-called armamentarium, and we can do sacral neuromodulation, and we can do antegrade colonic enemas, we can do colostomy, ileostomy, sigmoidectomy, colectomy with ileorectal anastomosis, pull through, pouches, and so on. But it's very difficult. When I see these patients, I'm always thinking, what should I do in these patients? And the first thing you have to do as a doctor is, and we have always the same dilemmas, is when should we do an antegrade enema? Should we do a colostomy? When to remove the ostomy? Should we do a resection? Is there any possible prediction of success, and which diagnostic text should we use? And what should we tell the parents? And is there some psychology, or is in some cases is there a factitious disorder? Now, as a doctor living in 2020, we always go to the literature and are looking for evidence-based medicine. And what I want to do is to talk about the review of Seminas, in which he did a systematic review about all literature concerning surgical therapy for intractable constipation, and then talk about our Amsterdam experience, and maybe we have some time still for the recent literature. The current surgical management of pediatric child constipation is in a summary in a study from Seminas. He published in 2015, and the commands you can give in general is there are 45 studies, in 91%, it consists of case series with patients from numbers from 3 to above 100. And in 91% of the case studies, there was an absence of a clear definition for constipation. And absence of duration of symptoms or medical treatment, 89%. And success was different defined. And there was only parent and carer satisfaction in 18 and 35 patients. Now, when we look more in detail in this systematic review, you see that when we go to the pelvic floor interventions, you see this were all near all case series, 2 randomized controlled trials, and the pelvic floor intervention consists of a myectomy of the internal anal sphincter or Botox. And what we can say is that now Botox is still used. If we know that is an outlet obstruction, we can use Botox with a success from 78 to 100%. But myectomy and dilatation is abolished. We never use it anymore. Then looking to the antegrade continence enemas, we are talking about, in general, talking about them alone, but the Malone is originally described by Malone. That is the so-called appendicostomy, in which the appendix is used as an entrance for the colon. But we talk also about ACE when we have it about cecostomy, in which we make a direct connection between the skin and the cecum, and we are using different types of buttons. Now this is the Malone. You see, you cut off the top of the appendix, and you make a plication with in which you try to have a continent stoma, and then you reimplant it and opening on different places, and you can use it every day to put in a catheter. And for antegrade, these are types of cecostomy. This is the so-called jade button, and this is a Mickey button used as the entrance to the cecum. Now, the results of ACE are here in this picture, and you see that there are a lot of case series in which 505 patients are described. The success is, yeah, I think it's good, from 33 to 100%, and in the mean 82%, but it's a lot of complications, but also a lot of reoperations. And the complications are mainly pain, skin problems, and leakage. Now, in general, you can say that the ACE showed better outcomes for incontinence than for constipation, and especially in slow transit constipation, we have bad results in Amsterdam. And cecostomy showed lower complication rates than the classical Malone. Now let we go to the ostomies, and this is a citation of Dr. Lyons that the vision of an ileostomy, this most lay persons, as well as all too many physicians and surgeons, have the horror image of the constantly discharging interstitial stoma, and think that death is preferable to an ileostomy. Now, with this citation in mind, you see that in the studies in the systematic review, there were only a small, only 5 case series with 41 patients in which an ostomy was performed as a treatment option for intractable constipation. Now the success rate was high, but the complication rates and the operation rate was also high. And the most complication you saw most is the prolapse. So in this picture on the right side. And then the last part of the systematic review is the resections or pull-through operations performed. Is also only 83 patients till 2015 were described. It were all case series with different types of operation, and the success rate was also different from 22 to 100%. And especially Levitt, he has always 100% and never a complication. We can talk on this later, but the complication rate is also high. Now there was a failure in 20%, reduced surgery in 12%, and complications till 25%. But comments on the resection was that in all the studies, near all the studies, there was missing follow-up data, and in one study even showed 78% of failures, and in all the studies are limited numbers of patients. This is one picture of a colectomy I performed in Amsterdam. So at the end of this literature study, as I'm a surgeon and want to know what to do with patients with intractable constipation, is I only see small retrospective series, expert opinions. The complication rate is considerable. So surgery for functional constipation is not evidence-based. Now let's talk a little bit about sacral neuromodulation. The last 10 years, there's more and more studies we see concerning sacral neuromodulation, in which the nerval, especially the S3 route is influenced by stimulation, electrical stimulation. And these three pictures are from the classical stimulation with an implant in the right of left buttock. But nowadays there are in literature 3 types of stimulation, in which the sacral nerve stimulation of sacral neuromodulation is the most popular. But it's also possible transcutaneous stimulation and also tibial posterior stimulation. Now, what happens after the stimulation? You see, as showed by Dining in the British Journal of Surgery, that after sacral nerve stimulation, you see an increase in bowel movements. The exact mechanism why it works, we don't know. And in this slide, you see a systematic review that the implantable neuromodulator overall has about 40% of complications, and in 72% a redo surgery is needed because of dislocation of the lead, or the battery is not functioning. But the results are there is an improvement in constipation symptoms in 80 to 85%, and a resolution of symptoms in 40%, and even a reduce in the use of antegrade continence enemas needed, or transanal irrigation. Now, the comments on sacral neuromodulation is that it's very expensive, and in the Netherlands it's only used for patients over the 12 years, and at the moment is in the Netherlands a randomized control trial to see if it's really has the benefits as it is claimed in some studies, because the highest success rates till now are coming from 1 or 2 centers in the world. Now, what's the Amsterdam experience in functional constipation? I started already with we have a lot of patients every year, but till now we operate in Amsterdam about 10 to 15 patients a year for intractable constipation. And from 2010 till now, I operated on 104 patients, and I'm involved in all these patients. And what we know and I learned is that these patients with intractable constipation are very difficult patients. The most difficult patients I have ever seen in my surgical career. I wanted to become a surgeon because I hated psychiatry and psychology. But when you decide to treat these kind of patients, you are automatically involved in psychiatry. Now, one of our publications is the study of Kuizinga, 2016. And we have the same dilemmas as I already earlier mentioned. Now we have at the moment a multidisciplinary dedicated team in which near all these specialisms are represented. And when we compare our results of the ACE in the past with the results of the systematic review, we see that we had a lot of more skin problems, we had a lot more leakages, and we had a lot of stomal stenosis needing a reoperation. The success was nearly the same, and therefore we decided to stop with the classical Malone to go over to the so-called jade button. It's a button you can use in a sulcostomy. We have now done more than 50 procedures, and it's possible that a radiologist is doing this procedure. And we start this procedure with putting in a pigtail in the cecum, and we anchor the cecum to the abdominal wall. And then after 6 weeks, when there is a channel, we change the pigtail for the jade button. You see here on the left upper side are the anchors. This is radiological, the anchors placed, and then we put in a pigtail. But it's also possible to perform sulcostomy. This is laparoscopically assisted sulcostomy. We put a few stitches and we fix the cecum to the abdominal wall and then insert a pigtail under surgical vision. Now, what we decided to change the system, but we have still problems. And what is the failures? It's because of pain, or it doesn't work, or we have ongoing leakage. But one of the most the problems I see is that near all patients, if they want to change the button after 3 to 6 months, we need sedation, and that's difficult, and that's not necessary if you're using the classical Malone. Now, this is one of the complications of a radiological. We had a wire fistula, and we had to remove the anchor. When we compare the results of the ostomy studies from Seminas with the AMC, we see we have near the same results, but redo surgery is more than about 1/3 of the patients need a second procedure. But sometimes it's very hopeful. This is one of the emails Dr. BENNINGA and I got in the past, that parents were very happy with the ileostomy we put on in our patients, and she said he has his life back. And now with these mails, despite all the problems, we go on and with what we are doing. Now, this is a patient with intractable constipation with a very dilated rectal sigmoid. We resected. Now, the resections we did from the manuscript in 2016, we have now more, but were ileostomy, sigmoidectomy, but a lot of patients needed a second surgery, especially the patients with slow transit constipation. They started with an ileostomy, and if this is successful, then they become older and they're in puberty, and they ask, can you remove the ileostomy? And then we go over to a subtotal colectomy with an ileorectal anastomosis. But from all procedures, we have failures. So sometimes a colectomy doesn't work, and we went to an ileostomy. We have also failures of colostomy, that we had to put on an ileostomy, and also failures of sigmoidectomy. We needed a subtotal colectomy. Now, more recent literature is focusing on neuromodulation, and these are the results of the long-term results of neuromodulation in the Netherlands. And then in this study, they compare the children on the left side with adults. You see that after the mean follow-up of 47 months, it's effective in near 50% of the patients. Now these are a few slides of transcutaneous stimulation, which also showed that there is a higher defecation frequency after the use of the stimulation. And this is also electrical stimulation, resulting in an increased bowel actions, decrease in soiling, and a decrease in abdominal pain. And this is another study in which there you see there's a decrease in laxative use after electrical stimulation. And sometimes people, this study is a very special study from Columbus Hospital in Ohio. And now I'm happy if one of my patients has an ACE, then I think, no, I'm happy. But in the Columbus, they are not happy with an ACE, and they ask the patients who are successful with the ACE to use sacral neurostimulation, and then see if they give them sacral neurostimulation, that the use of the ACE is decreasing. Now, if I have nothing to do, I can think about this strategy. Now, this comparison, here's the combination, that comparison of ACE treatment and sacral neurostimulation for children with, and you see after result that the rate of complications requiring surgery was similar between both groups, and the benefit was reported in 83% for the ACE group and 100% in the SNS group. Is one of the study of Glasser, who retrospectively, by the use of social media, found a lot of patients he operated in the past, and they asked what they found about the result. And now the patients were very satisfied with the surgery, but on the methodological and retrospective base, you can have a lot of comments. And one of the last studies I want to talk about is the study of Levitt, recently published in the European Journal of Pediatric Surgery. And now, yeah, it looks easy if you see this scheme from A to F. Now, you can make a choice, but the problem of this study is that it's in this complete study there are no data. It is only expert opinion, and then finally this is the conclusion of his expert opinion, and then you can use it. Now you can discuss it if it's really the solution for the problems, but it's the typical way. One of my colleagues, Levitt, is a pediatric surgeon. He's well known in the world for anorectal malformation. I think he's a great man in anorectal malformation, but about constipation, I don't know if he really is talking about, if it's what he's talking about is reality. And this the last study I want to mention is from Gupta, also published in the Journal of Pediatric Surgery. And yeah, it is a study based on manometrical findings, and on the findings they decide if it's better to do if you have a left side dysfunction of the colon. Yeah, you can expect that an ileostomy is more successful than a colostomy. So now at the end of this talk, yeah, what to do? I don't know. This is one of the algorithm. This is coming from the study of Seminas. I think, yeah, you can work with it, but one command on it. If it's if in our experience is that if retrograde colonic irrigation is not successful, then according to this algorithm, you should start with an ACE. But in our opinion, if a retrograde colonic irrigation doesn't work, in most of the cases, an ACE antegrade colonic enema is also not working. Now, the conclusion: surgery for refractory constipation. We are still struggling because mainly retrospective case series with expert opinions. The overall complication rate is considerable. There are incomplete workups, so we don't know which test is the best. No clear strategies in near all studies, and the prediction of success is difficult. And therefore, when Mark and me are talking with the parents, we are all, we are always saying we cannot say if it's successful or not. And I think that's the only real thing you can say to the parents. And most studies are limited numbers, poor quality, and there is also a limited predictive value of the diagnostic tests till now. And I think that sacral neuromodulation is a promising therapy, but we have to wait, I think, results from other centra. And I think an ACE is the first surgical option which you should use in intractable constipation. And ostomy or resection should be the last resort. Thank you for listening.
Thank you very much for a really interesting walk through the difficulties of the surgical management of constipation. We're now open to questions, and I'm going to take the moderator's privilege and ask the first question. I want to ask you, Dr. de Jong, so it's very interesting when you think about retrograde washouts and ACEs, and I do quite a number of joint clinics with my paediatric surgical colleagues with children with anorectal malformations, spina bifida and such like. One of the big issues I think in that group of patients is whether you have a washout or an ACE or another intervention, you still have to sit on the toilet for a bit of time, and that seems to be a hurdle for some of the children. I just wondered what your experience was, because I think often when an ACE or washouts don't work, because we can't get the child to sit in the toilet. I just wondered what your comments on that, because a number of these have got other medical issues, but how do you manage that problem?
We prefer to start with rectal washouts. I think everybody prefers it, but in the case of anorectal malformation, it's always a problem. But should you start early with rectal washouts if you have some high anorectal malformations, which you know that it's for sure about 80-90% sure that in the future you need rectal washouts, then I think it's better to start early, because when you start about 3 or 4 years old, the children are very resistant and don't want it.
Yeah.
And if it doesn't work, we have a lot of patients, they start successful with rectal washouts, but during treatment, when they become in puberty, they resist any longer to put in a catheter rectally. And then sometimes we decide to go on for antegrade colonic enemas. But your question was if also an antegrade colonic enema doesn't work.
No, my thing is that if you how you get to make progress when they won't do the bit they have to do, which is sit on the toilet for the washout to be released, or for the antegrade continence enema to work. I mean, we have obviously, like you, a mixture of successes and failures with this group, and I wondered, what your experience was of that group where you can't get them to sit on the toilet.
You can't get them on the toilet. You mean the what type of patient do you need?
Yeah, it's the children. I mean, it was really just a comment, perhaps, that we have a number of children where we might consider an ACE or a washout, but we can't get the child to sit on the toilet to release the stool once they're being washed out. And that's where our we have to work very hard with our surgical nurse specialists to get these children to work with us when we're using these therapies. I can move on to some of the questions. We've got quite a few questions on the feed. So there's a great one for you, Mark. How do you decide which non-pharmaceutical therapy will be the most successful for a specific child? I think that's great. And I'm always a bit jealous because you can access hypnotherapy and we keep working out how we can try and do it. But it's a good question, isn't it? Which do you use? Is it just what you happen to have, or what's your preference? Mark, you need to unmute.
So there is no good answer on this question because both therapies have shown to be effective, like behavioral therapy or hypnotherapy. However, in my experience, many parents are more likely to use hypnotherapy because if I send them to a psychologist, they always think my child is crazy. And although I can always explain it's not the case and they help you in a different way, then they are in the Netherlands more likely to go to a hypnotherapist. But I don't have a specific reason to send one patient to hypnotherapy or to a psychologist. On the other hand, very religious people don't want to use hypnotherapy. So I never can send these people to a hypnotherapist. I don't know exactly why, but they are not in favor of doing hypnotherapy, and they would more likely to go to a psychologist. In the last 2 years, we are working very hard because we showed, as I showed in my presentation, that the CD, which you can download from the internet, is helpful as well, as helpful as the therapist. And we now translated our own website, which is called Hypnose bij buikpijn.nl, where you can just download the 6 sessions as used by the therapist. And we have now translated in different languages, as well in English. So hopefully in the next few months, you are able to send your patient to this website and they can download the sessions. But to answer the question, there is no specific reason to choose for whatever behavioral therapy.
I mean, can I ask you which has come through on the screen? So you did talk a little bit about yoga therapy, and you know, one of the things that was I question in my mind is it that it doesn't work, or is it that we haven't got enough evidence? And do you think that that yoga therapy's got good potential for functional pain? It feels to me like it should have good potential, but I wondered what your thoughts were.
Well, unluckily, there's only one study. It's a small study, and it shows some benefit, although the benefit was only shown after 1 year, which is in most of the behavioral therapies, the success percentage increases during the year, and only psychologists can really explain why this is, but it's shown in all these studies. And I agree with you that there is a potential for yoga, and again, it depends on the parents what they like most to choose from. But now, if you only look at the evidence, there's clearly far more evidence for cognitive behavior therapy and hypnotherapy. But I agree with you, there is a potential.
So there's a question come through which it says, I commonly see parents dismissing the pain and additional stress to the child. I think possibly what the question may be talking about is when patients will maybe keep focusing on an organic cause of the pain rather than accept that there might be a functional component. And I must say, one of the things that I do, and I now have this specific discussion, I say, well, you know, are there any stress factors? And the patients sometimes and the families will look at you and say, oh, no, please don't say my child's mad. But actually, I then say, well, you know, stress, I mean, like, has he had a really serious viral infection recently? Or has he been unwell in some other way? Or has a family member been unwell or another way? To try and emphasize to families that when we talk about stress, which leads, of course, to anxiety, then we're not just talking about a psychological stress. To try and help the family believe that you don't make a distinction between physical and psychological, and that you try and think of them together, and I think that works. I don't know if that's your experience, Mark, but
yeah, well,
we have to hook the families in, don't we, to get any sort
of
of
course.
ability.
But because as you do, I draw a lot of attention to this particular problem we daily face with as healthcare professionals. I make a drawing and I show them that there is a clear continuum between the brain and the gastrointestinal tract. And I always tell my own story, telling them when I give a presentation, I'm a little nervous at that day and I go more to the bathroom than when I'm not giving this presentation. It's not that I'm a psychological wreck or I'm strange in the head. No, this is a normal response from the body, which gives rise to a little feeling in the abdomen or in the bowel or whatever. And at the same time, I have to go to the bathroom more frequently that day than on other days. Hopefully showing them and explaining them that the brain and the gastrointestinal tract is in continuum. And I never use the word psychological because I know these patients hate them. And you showed the beautiful study done by Keith Lindley in the old days. If people are not able to leave the concept of organic disease, then it's very, very difficult to treat them.
So thank you. So there's another question come through. There's two questions actually, and they're good questions for you, Dr. Young, to think about. I think the hardest question is the first one, which says, when should kids with functional constipation have surgery? So then another person has asked a similar question, but they've said, if surgery is deemed necessary for a child with constipation, does that mean the doctors and parents have neglected the situation? So I guess, I mean, they talked it. One of the questions is put about a 3-year-old, but it's, when do you get to surgery, and is it because it's failed? And of course, there's never a straightforward answer.
But I always, I know from Mark, when he's visiting all conventions, he has always to defend himself, and they say, yeah, you put on ostomies in all your patients, but I always explain to my colleague surgeons in the Netherlands, we have a unique situation that we have 70 million inhabitants in the Netherlands, and we are the last resort center in the Netherlands, and all patients with intractable constipation come to Amsterdam. So we have a relatively large group of patients, and they are seen mainly by Mark himself. And Mark, in most cases, thinks, Justin, what do you think? Surgery or not? And yeah, I think it's for near every patient is difficult. Well, Mark, what?
I could add to that, because the decision is really, really difficult, and we explain that we are not sure what to do. Probably, and I'm always surprised that not many people recognize this wherever in the world, because constipation is so common. But at the end of the day, we as doctors tried everything, and if you're sure that the compliance of they use their oral or rectal laxatives, and the child is still severely constipated, and you can show this with additional testing, and you, for instance, we use the transit time test we use often in these children if I don't understand anymore what's going on, and you still see that there is severe constipation, not and really treatment resistant, and the fecal incontinence is daily. And I tried all the different laxatives, like even lubiprostone or prucalopride or linaclotide. And at the end of the day, if they still have problems, everybody is really sad, and the child is not going to school. Then I call my colleague Justin, and then we start to talk about it. But before we take the decision, we bring the patient in our multidisciplinary group. And there is a psychiatrist, a psychologist, a general pediatrician, a dietitian, health, how do you call them, mental health worker. and then we decide together, okay, are we ready to do whatever surgery? So and then we're still uncertain about the effect, but as Justin showed, I think, well, 50 to 60% people are really satisfied that especially the fecal incontinence disappeared. So yes,
I mean,
the
I would
decision is
agree.
very difficult, and I dare to say that we tried everything before we asked the surgeon to help us.
Yeah, and I agree. It's a tiny, tiny subgroup, isn't it? But
Yes.
you know, when you're stuck with someone who's got persistent fecal incontinence, and despite everything you're trying, you're not making an impact, then the brave decision is to do something else. And I think sometimes we don't do anything because we think we shouldn't resort to surgery, but actually sometimes you can transform the young person's life. Then the next question that's come up, I think is quite an interesting question, isn't it? So what probiotic would you use in children? I mean, they asked me and I don't know the answer to that because I don't really know what you should
Nobody
do.
knows. Nobody knows.
I have an anxiety that, I mean, in the UK, that there's often an accusation that probiotic capsules that are sold have just got dead bacteria in them. So because our quality control of foods is better, I sometimes tell them to use live yogurt, but I never know quite which one. And I always say, try it. We can't prescribe it. So I say, try it and only continue it if it works. That's probably like any other medication. The other question they've asked is about peppermint tea. Well, yeah, I mean, I think peppermint capsules, peppermint tea, they're helpful. We can't prescribe either. I don't know if you can, Mark, but it's the same discussion, really. If you find something that helps you and helps the pain and makes things better to manage, and these are usually kids that have got an IBS component, then yeah, it's a good idea. But I don't have specific recommendations.
The amount of peppermint oil in just the little the peppermint sweets or in the tablets as used is less, but we don't know if only a small amount of peppermint oil in such a peppermint sweet is enough to improve pain. But you know, the same is true with the placebo effect. If you sell the peppermint tea or peppermint capsule that it works in almost all patients, then for sure it will help more than 50% of the patients to diminish the pain. It might act as a placebo. The same is true for the probiotic strains, but you really have to sell it that it works very good in many patients, but which particular strain is unknown.
But if you can get a 41% success rate with a placebo, it's not bad.
Not bad.
The other question that's come up a couple of times is about long-term outlook. And I think this is really important because it's why these three topics, the three talks, I hope are interesting and helpful, because there isn't much data, but it does seem that if you've got functional problems in childhood, you're at high risk of functional disorders as an adult. And if you've got functional disorders as a child, then you've got high incidence of anxiety and depression as an adult. It also seems to me that quite a lot of the patients that we see that are the most difficult to treat have significant anxiety, and we have to try and address and manage that. But would you agree, Mark? You know, there's a lot to invest in children with functional abdominal pain and a lot to invest in children with functional constipation, because you can improve their health in their adult life.
That's true. There are not that many studies looking at the long-term follow-up in these patients. We did look at it in our cohort in the functional constipation group, and 20% of our patients, but again, we have a biased population with the most severe cases in the Netherlands. So 80% is cured at the age of 18. The Italian study from Andrea Saiano showed that after 5 years of intensive treatment, 50% of the constipated children is still having constipation. But so at the end of the day, the majority of patients will get rid of the constipation. But we do all know that some of our patients will grow up with constipation when they're adults as well. And the same is true for abdominal pain, although there are no good studies really looking at abdominal pain as a youngster growing up as an adult with abdominal pain. But I'm aware of studies, they say that approximately 20 to 25% of the children with abdominal pain will end up as adults with abdominal pain as well. And then I agree with you, many of these patients have either anxiety or depression or whatever comorbidities.
I was missing in the talks something about acnes. Do you know it in the UK?
About
Anterior abdominal cutaneous nerve entrapment syndrome.
Yes, but that's not a functional disorder.
Oh no, it's not a functional disorder. But it's sometimes you have patients you think that they're functional and they have acnes.
Yeah, I'm sure. Well, but that's always quite an issue, isn't it? I mean, I think sometimes we should make a positive diagnosis of functional symptoms and remember that it can coexist with other organic disorders. So, you know, we see a lot of functional children who've got something wrong with them as well, where the way in which they manifest that has got a functionality to it. And my evidence for that, which we're trying to think about how to put together, is we brought a half-time psychologist into our inflammatory bowel disease clinic, and certainly a significant group of adolescents are doing very much better by having the functional component of their serious organic disease dealt with. Can I ask you just on the tag, just in one question? So we do recognize, don't we, these very difficult group of constipated patients, some of which require surgery. And any thoughts about what happens to them in the adult clinic? Because we do have some adult colorectal surgeons who've got a lot of expertise, and certainly they are interested in quite a lot of the interventions you've talked about, and they do end up doing surgery, even sometimes resecting the sigmoid, as you had in one of your lists. And you know, because some of these young people I worry about when they move to adult services and what happens, because they're struggling.
It's an interesting question. This is one of the nightmares of MARC. Also, that I'm also an adult surgeon. I have a pediatric surgery, but I'm also doing adult surgery, and we have seen many patients when they are 18 and go over to transition to. There's in the Netherlands no surgeon really interested in these very complicated kind of patients with a long history. Also in our hospital, it is a famous hospital, Amsterdam, but no adult gastroenterologist is really interested, and they say it is not our point of interest. And so for surgical point of view, all patients are followed by me after they are 18. But for the gastroenterological point, it's difficult. I don't know in the Netherlands, no one who is really interested.
Yeah, that's interesting. And I think we find that, and it's interesting that the morbidity of some of these patients we've been talking about this afternoon is very, very high. And yeah, it's a worry, because we can offer a different sort of input in pediatrics that often is offered in adults, and certainly our adult gastroenterologists, the majority of them. I mean, there's a growing group that are interested in neurodysmotility, but there's a significant number who wouldn't consider this part of their core business.
We have a good example at the moment. It's a patient of MARC in the past. As a girl, she's now 18, and for maybe 3 years, MARC, it is functional constipation is the problem, but also psychiatrical things. And she did not eat for 3 years now. She's using parenteral feeding. She's staying at home for 3 years now, and she's now just 2 weeks ago became 18. And after many talks, she finally decided to go and ask me what I should do. And I suggested an ileostomy. And now, everybody was very exciting surgery in this girl. And we are now maybe 4 weeks after putting on the ileostomy, and the girl is now on 250 milliliter of parenteral feeding, and she started eating again.
Yeah. So we've no more questions. So I was just going to draw the session to a halt. I would have to tell the audience we don't know who and how many and where you are if you're listening, but I hope you found it enjoyable. we haven't got time for a poll, but it might be that we'd all three of us agree with, you know, if you're seeing children with functional disorders, definitely think non-pharmacological. And maybe, would you agree, Mark? Try and think non-pharmacological before pharmacological. Because of course the pharmacological bit, the drugs, that comes easily. That's what we do as doctors. But think of the non-pharmacological strategies and thinking that we've talked about this afternoon. And I think that would be my take-home message.
I would like to stress that functional gastrointestinal disorder is a positive diagnosis. So don't circulate it as a healthcare professional around it and say, this is my diagnosis, I'm sure about it. We don't have to look for organic disease, and now we have to go on together.
Good. I think we can then close the session. Thank you very much, everybody who's listened, and thank you very much for Mark and Justin for your great interaction chat.
Bye. Bye.